I'd like to move on to talk about alpha-synuclein targeted therapies, and many of us are familiar with that term, alpha-synuclein. As a quick reminder, alpha-synuclein is a protein that's normally found in cells, but in the brains of those with Parkinson's, we see these proteins misfolding and clumping into Lewy bodies, which is thought to be a bad thing and may contribute to the death of cells. And this has led to treatments directed towards alpha-synuclein pathology. In general, how is this targeted?
Yeah, great question. And of course, we focus a lot on alpha-synuclein, and not to be too much of a windbag of history, but it turns out that, way back, in Italy and Greece, there was this group, this family, this huge family. And, back in the early 90s, they started to, look at genetic samples, do some linkage analysis, see how they link together. And they realized, oh my gosh, they're making too many copies of this thing called alpha-synuclein. And it was a big deal. And somebody in that original, paper said, we should look to see whether alpha-synuclein is in these things called Lewy bodies that we're seeing all over the brains of people with Parkinson's disease. And of course, within 6 months to a year, they had said, of course, it's an important piece to that. And so it turns out to be like one of those breadcrumbs that has become really important for scientists. So the proteins depositing in the brain. And then the question is, the big debated question. Let me tell you, there are hot debates on this. Hot. I mean, hot as, boiling water. Okay. If it's too late or not to go after these things once they've deposited in your brain. Okay. And or do we need to get to them earlier? And so there's a number of different, what we call alpha-synuclein targeted therapies. The idea is to reduce their aggregation, reduce them piling up in the brain, and enhance the clearance. By the way, Sonia, if you sleep well, when you sleep, what happens? You clear things out. That's one of the things. We didn't actually understand why you sleep. It's really important. It's kind of like if you have a party in your house, and and everybody comes over and they make a mess and the dishes are stacked up and there's plates and cups everywhere. They go home, they leave us to clean it up. Everybody knows about this feeling, right? Well, it turns out that that's what your brain looks like at the end of each night, and it looks even worse, okay, right before you go to sleep if you have Parkinson. And well, once you sleep, there's a system called the glymphatic system that clears those things out, okay? And so we're talking about is clearance of things, which is a good thing. So even talking about alpha-synuclein therapies, we talked about sleep a little bit earlier with obstructive sleep apnea. Try to get to 6-7 hours of sleep, even if it's fragmented. Super important to clearing things out of the brain. Now, back to synuclein. What about clearing synuclein out? So there's a number of different drugs that have been tried. I can't say any of them right, but I'm going to try, okay? Presidentimab, okay, is one. And buntanetap is one, and Ambroxol is another one that people talk about in this. And so thank you for your kindness in allowing me to mispronounce these drugs. But what they do is they reduce aggregation and enhance clearance of this. And they work as kind of like antibodies with your immune system. And so, they are sort of targeting these areas and they're going to try to remove them. Okay. And the idea is that they're going to try to slow disease progression. Okay. The first one, the presidentimab, that one had a mixed signal, Sonia. And there was a study called PADOVA, PODOVA, if you read about it, and it didn't meet its primary outcome. These trials appeared in the New England Journal of Medicine. There has been an emerging reanalysis of some of the data past the primary outcome. And despite the fact it was negative, there's still an advancing program to do another large study because there may be, real, even if modest disease modifying benefits. And so they're trying to prove that now.
Right.
That one is one, you get through your IV, right? The other one is there's an oral translator, what's called translational inhibitor of synuclein, and that's the buntanetap. Am I saying that right, Sonia? Do you think?
Let's go with that.
Let's go with that. Okay. We're just going to go with it. Everybody, if you all are struggling, guess what? So are the so-called experts. We don't know how to pronounce these things either. So this has a different approach. It reduces the production of alpha-synuclein and these toxic proteins in your brain. And it does it at the what's called the mRNA level. So that's kind of where proteins are built. You've heard about, about that. And there's the phase 3 trials, there's sort of this nuanced way of looking at it. It had good safety. The endpoints were hard to interpret. Maybe there was some benefit in cognition and motor scores. Maybe it's going to help us drive it, but it wasn't robust. So neither one of these has been super robust. The one that's been most interesting is the cough syrup, okay? Ambroxol and the GBA pathway. And again, at the end of the night, you got to clear things out of your brain. One of the mechanisms of clearing out that garbage control in your brain is called the lysosome for clearing it. And one of the things that Ambroxol, one of the components of that cough syrup, and Tony Shapiro and colleagues have published some wonderful work on this. And the idea is that it increases glucose cerebrosidase or GCase, which is the enzyme that does this, and it directly targets this clearance. Okay. And the clinical results have been, modest. There's been some good safety and biomarker data. The Cure Parkinson Trust is doing a study both in people who have GBA1 Parkinson and people who don't, and who's going to benefit, if anybody's going to benefit from raising this approach. So there are multiple ongoing trials in this area. And the bottom line is that, when you think about prasinezumab, that's sort of an antibody approach. When you think about buntanetap, that's a production blocker, okay, of synuclein. And when you think about Ambroxol, that's a lysosomal enhancer or an enhancement of taking things out of the brain. The unifying issue between all of these three is that they all target alpha-synuclein biology. Some of the data is compelling, hasn't been, super robust in terms of the clinical benefits that we've seen, difficult to translate. And then one other thing I will mention is some people actually think the opposite, and they think that one of the treatments might be to actually push up the synuclein levels. And so Alberto Espay talks about the difference between clearance and what should be there and what should not be there. And we should always be thinking about the alternative hypotheses right now. That's where we are. We are seeing antibody therapies in Alzheimer's disease ahead of Parkinson's with mild benefits there. And so perhaps we will get to some therapies here that will have some mild to modest benefits. And so we remain cautious here. So far, the data has not been awesome.
Right. Thank you. The other word or term we've kind of thrown around today is inflammation or neuroinflammation. And there are some neuroinflammation-focused treatments. Inflammation in the body is really just a response to some sort of injury or infection or disease, and it's part of the body's natural defense and healing system. But another factor in the progression of Parkinson's disease, we believe, is neuroinflammation, which is normally activated to protect the brain, but when it's overactive, neuroinflammation can actually damage neurons and we think progress neurodegeneration. So researchers have been targeting this kind of overactive neuroinflammation, and some of those drivers of neuroinflammation have been targeted, such as I think it's NLRP3 is one of them, NER1 is another. Could you sort of explain what this means about targeting neuroinflammation?
First, I love that both you and I struggle with all these names. It makes me feel so much better. So thank you for making me feel better. So one of the, I think, principles that is super important for people to remember is this word that is emerging that you're going to hear more and more about called inflammasome. Okay, we talked about this in the Parkinson plan as well, because we interviewed people from all over the world about all the new therapies, and there's a whole section about this. And it was fascinating to listen to what people thought about where things were going. But this was one that drew a good bit of attention. And an inflammasome is like a tiny alarm system that's inside the cells, of your brain or of your body. And when it senses like danger, like infection, toxins, or cell damage, it activates and it triggers inflammation as a way to protect the body. Okay, as a way to protect the body. But Sonia, if this, indicator light stays on too long, okay, it can contribute to diseases, we think, like Parkinson's and Alzheimer's. So that's sort of the theory, right? It's good. It sets it off. Inflammation's actually a good thing, for protecting you. But if it stays on too long, this can be a problem. Okay. And so when we think about these inflammasomes, now we're trying to think about, oh, okay, we have got lots of smart people. Why don't we target them? Okay. And so if you read about some of these studies, the DAPA PD study, the DAPA PD study, if you read that, that one is called dapacetrel. I don't know if I said that right, but anyway, it's the NLRP3 inhibitor. Okay. And so if you see DAPA, like give me some DAP, the mechanism of action is it's going to target the inflammasome, and the name of the inflammasome is what you just shared, NLRP3. That's just the name of that inflammasome. What does it do? Okay. It drives something that is important to the scavenger cells of your brain. So you have to have these cells that go and they take things away. When you have death and destruction and things, it's got to go clean everything up. These are called microglia. They're called macrophages in other parts of the nervous system and of the body. But in the brain, we often call them microglial, cells, and it activates them. So DAPA activates them and neuroinflammation. And when it does that, it's going to reduce a whole bunch of these inflammation cells that come out that we call cytokines. And anytime people listening, when you hear IL-1 or TNF, these are all sort of these inflammatory response cytokines. So when you hear that or you read about that, you say, oh, okay, wait a minute, maybe we're talking about the inflammation system. Right. And the idea is that could we directly treat the inflammasome as a way to either reduce the inflammation, Parkinson, and slow disease progression? So they're still in early days, what's called a phase 2 trial. And they're really focused on these microglial, these clearance cells. And the idea is that if it works, maybe it will work for not just Parkinson, but it'll work for other degenerative diseases. Now, when we look at other approaches to this, there is another one. It's a brain penetrant NLRP3 inhibitor. Okay. And if you're reading about it, it might come across your desk as NT0796. Please don't go to your doctor and say, have you heard of NT0796? Okay, it's made by NodThera. And this is another brain penetrant NLRP3 inflammasome, mechanism type of drug. It's going to work, within that same way. And so you can see there are companies, approaches, and scientists that are pushing along. We're also seeing people use stuff that's on the market and we repurpose, another R, Soania. So repurposing azathioprine, okay, which can suppress the immune system. We saw sort of a failed trial here recently in another neurodegenerative disease. It's being looked at in Parkinson. Hasn't been super robust, but the idea of repurposing immunosuppression is something that people are talking about, and there's some proof of concept with it. It's it hasn't taken off like we thought it would, and as the early data is coming in, hasn't been awesome. These are things that when you suppress the immune system, you can cause more infections and things, and so we have to be really careful about this and clever in the way that we do that. The other way you can do this, Soania, is you could use an immunotherapy response. That would be like a vaccine type of response, and some people, as you're reading, you might see ACI 7104 or UB312, and you say to your doctor, what do those things do? They're going to have to stop and look it up. I mean, if they know all of these numbers, I'd be super impressed. But that vaccine approach is going to try to train the immune system to clear or prevent aggregation and reduce what are these, we think, protein-driven inflammation, okay? And so it's going to generate antibodies against this. It's going to try to clear out and bridge neuroinflammation and bridge the proteins that are depositing. So some people call it both working on neuroinflammation and working on the proteinopathy, too much protein deposited in your brain. There's another anti-inflammatory one that works sort of in the insulin group, and people have probably read about, diabetes and Parkinson's and more type 1 diabetes and Parkinson, and even a little more in type 2 and insulin resistance, and you're getting your blood checked. You're like, why are all these people with Parkinson have insulin resistance? Is there something to do with the nervous system? Well, if you read about a study called Sunrise, the Sunrise PD study, they are looking at a compound. It's called bezisterim, And they're looking at this compound combining anti-inflammatory effects and insulin sensitization to look at systemic inflammation and effects on trying to treat the metabolic system. And so that is another, sort of really interesting, way to look at this. And then there's also what are called platform trials, where people are going to try to put multi-arms of things together and multiple agents together. And you might read about the ACT-PD platform trials. Those are in the inflammatory area as well. Some people call them the EJS ACT-PD platform trials. And they could test multiple agents, okay, that have anti-inflammatory and other effects together. So one is called telmisartan, okay, which is an anti-inflammatory and vascular protective drug. Another one, terazosin, you may have seen. A lot of men take terazosin, blood pressure, prostate, other things. Mitochondrial metabolic support. And the UDCA, which is a compound looking at mitochondrial rescue. And so looking at multi-platform trials across multiple mechanisms that may bridge, the different things with inflammation could be super important and super interesting. We don't know, but we'll keep an eye on those.
Yeah, I mean, I think that, repurposing existing drugs and these multi-platform trials are really going to speed things along and sort of cut down on the time that we so desperately need to cut down on. There was also some questions that members of our audience have sent, are wondering about. One is FGF1, and there's been some excitement about that. It's an intranasal therapy that has been found to increase blood flow to the area of the brain that's responsible for producing dopamine. What's the latest update on FGF1?
Yeah, so FGF1 is one of those ones that it has been sort of, like people are saying, this is kind of interesting, right? Especially with the nasal, aspect of it. It's some people call it like the next coming of GDNF, so it's a growth factor promoting neuronal survival, another R, the reborn, the next, kind of level of things. And we believe that it works by supporting neural repair and also signaling of the metabolic system. Okay. Mm-hmm. And the idea that people are applying it for is, could it protect neurons? Okay. And could it help with regeneration? It's very early on. It receives much more attention, like in the news, than what we have in terms of clinical data. So let me just say that. And that frustrates a lot of people because they read about it, they read the early stuff. They say, FGF1, what's going on, with it? Well, we know it provides neurotrophic support for surviving and repair of dopamine neurons, and some of these pathways that are signaling that are really important. It also has anti-inflammatory effects, works on that microglial system. Those are those scavenger cells in the brain that take away things that you don't need. It works at the level of the synapse where the two neurons are trying to communicate, and might have some effects on circuit repair. And what's interesting is there's some metabolic regulation that happens with FGF1, in that it may improve glucose metabolism. And when you improve glucose metabolism, you improve the factories in your cells. One of the factories in the cells that's super important with Parkinson is the mitochondria. And so that's important. And then there's another mechanism they think, it supports vascular health and blood-brain barrier integrity. Now, having said that, when I say like all of these things that are potential positives, it's so early, we're not sure. So we're still speculating on, what it might do. What do we know in terms of data right now? We know the animal models have showed improved motor function and some protection of dopamine cells, but we've seen that in a lot of other compounds in other areas. That is nothing new that we see it work in animals and not necessarily in humans. So we need to see human data. The long-acting engineered variants have had, more sustained, effects. And of course, they worry about tumor risk in these drugs. So remember that. So a lot of scientists are looking at that. People love this intranasal delivery approach, as a potential for it being non-invasive. And so far, the anti-inflammatory signals have been high. The human trials haven't really, gotten started in any large sense. I've seen a lot of data on this. But this is one that I'm watching, and I think of it the way I remember FGF1, Soania, is this the next gen strategy after GDNF to try this in a way, and will it provide things that protect neurons impact inflammation and metabolism, sort of like a combination approach.
Perfect. Thank you. Low dose carbon monoxide sounds a little
Yeah, right. So,
dangerous.
so yeah, like it sounds a little nuts, right? And it turns out it may not be as nuts as we thought it was. And the idea is that there's a dose response to everything. And when you have either decreased oxygen, or low dose carbon monoxide, there may actually be an effect where your brain kicks into an anti-inflammatory, state and into something called cytoprotective signaling. And so that's when your brain sort of begins to become resilient and those pathways get upregulated to try to protect things. Okay. And so a lot of the old-fashioned data on Parkinson disease talks about oxidative stress pathways and how those cells get stressed out and the mitochondria and everything gets stressed out. And they think that low dose carbon monoxide might actually modulate those things. And
Mm.
actually, there are some trials, some clinical trials, that are underway looking at safety and dosing. And then also there's some clinical trials underway of low dose hypoxia, bringing down the amount of oxygen and intermittent hypoxia. Nobody listening should try these things at home, but there are, several studies, people are looking into this. It is interesting. And also just think about like, how could we trigger your brain to be more resilient? And so there may be something to this. And I always say people try to dismiss everything. And you realize like, there's usually a grain of truth to almost everything. And we just need to take the time, take the patience, and go a little deeper and see what's there. But don't try low dose carbon monoxide on your own. Let's get a little bit more data on that one.
Yeah, exactly. Any updates on focused ultrasound?
Yeah, so focused ultrasound, a therapy that uses sound waves, been around since the 1950s or even before, but now the technology's gotten so much better for delivery. It makes a hole in the brain from outside the brain without putting a burr hole, through the skull. You shave the head and you can put it into an MRI machine and make a hole deep. More and more data, that's emerging. A lot of the early data came in essential tremor. Now there's some data in Parkinson disease. People tending to do it unilaterally more than bilaterally. And now the latest thing is that they're beginning to target a pathway, an outflow pathway from the pallidum, which is called the globus pallidus, in order to put in a second lesion on the second side in some folks. So it's early days on the data as it's coming along, but it has been effective, for tremor. Okay. And it has been effective in some cases for dyskinesia. And now we just have to see how it's going to do. And then, of course, so far, the two-sided lesions in the brain have been a problem for medical science in general, for causing irreversible side effects with speech and walking. And it seems that the latest studies that folks have been doing on focused ultrasound and separating the amount of time you do between the lesions, called staging. So you do one lesion, you wait, you do another lesion. If you make the second lesion a little smaller, you might be able to get away with that.
Mm.
There's fundamental differences between what you can and can't do once you put a lesion in the brain, but it's certainly emerging as another option, for folks with Parkinson disease. And so we keep a look on it. The other thing with focused ultrasound that's pretty cool is opening the blood-brain barrier in a number of these studies in order to deliver drugs. And so we talked a little bit, touched just a bit, Sonia, on delivery methods, but that's been the other area, is using it to open the blood-brain barrier to get drugs and to get therapies across.
Right. That's very important too. You're right. There's also been some questions in the chat about different therapies that we kind of hear about on social media and that sort of thing, bands that we wear or light therapy. And so my question to you is, how should those of us in the community approach therapies that we may learn about online or on social media? Like, how do we know what will legitimately work?
Yeah, so it's great that there's so much activity, and everybody's trying all sorts of things to help in Parkinson. Um, Sometimes it leads to overload, in folks trying to sort through all of these things that are happening. And so and sometimes people actually are good people, and they'll put a band or a wrist or something on, and they'll invent a device for walking or in the shoe or whatever, and it works for them. but it doesn't work for the majority or even more than the majority of other folks. And so we've learned that, over time, and then it can change because Parkinson changes over time too. So maybe it works during, some period that you have Parkinson. So I think it's wrong to dismiss all of the people outright that have developed things that might be helpful for Parkinson. I do think it's right, however, for us to try to help folks to, kind of work their way, through this and to realize that a lot of these don't end up as being robust. Even if you see it on a video or on TikTok or something like that, it doesn't end up being that robust. And so I think I say always have an open mind to it. Two, before you spend your money, on it, particularly some of these things can be very expensive. Make sure that you talk with your doctors, talk with your healthcare, providers and your team, and make sure you understand that. Three, just understand the majority of what we've seen. I have worked as the medical director, now medical advisor for the Parkinson Foundation for over 20 years, and one of the things people have claimed is curing Parkinson every month. There's a claim of a cure somewhere in the news every month, and so I wish that was true, but here I am 2 decades later to tell you, we just have to help you to navigate through these things. But it's also not. I don't think it's useful to tell people that these things don't work, because they might work for specific people in specific areas. And we should have an open mind, and maybe there's something in there that we can learn, that we can apply. But if there was a huge therapy that was working for everybody, if there was a cure, if there was whatever, Soania and I, we would tell you. We would not hold back on you. We can't pronounce the names of all these things, but we will tell you, like, if we think that there's something there. So that's kind of my approach. Well, what is your approach, Soania, as both a physician and as an individual with Parkinson?
Yeah, I mean, I'm excited about the research that's happening. I think we are moving forward. We're getting more shots on goal. But like you, if it sounds too good, it's probably too good. And you have to look at everything openly, but also with objective eyes as well. And we need the studies to show that there's a benefit to certain things. Anecdotal evidence is not enough for that. But so I do recommend that people do some reading about whatever they hear about, and also talk to their physicians about it. Because, like you said, Michael, we're not gatekeeping here. We're not gatekeeping this information. If there was something out there that would really benefit the majority of people, we'd be singing it from the rooftops. So, yeah, that's the way I would approach it.
Yeah.
Kevin in the chat actually said that he was really excited to see the increase in promising modalities in the last few years. But he asks, what's your advice for the person with advancing Parkinson's today when it comes to what's coming down the pipeline and in general?
Yeah. So my advice to people is this. One, remember that we are all on the earth for a limited number of minutes. We share the planet. And a lot of times, at least I grew up in a Western civilization, but in Eastern civilization, we talk about living as being important. And you'll see when I write a lot, I write about living and making sure that we appreciate, the fact that we're not here forever. I always tell my students, there's nobody in the room that here who gets to live forever, right? And so I personally want to do two things for folks. One, I want them to know that, that we can create a plan for you today, a comprehensive plan for you today, so that you can enjoy every minute of every day as maximally as you can. Davis Phinney, I'm wearing his hat here. And Davis said, he always says, make every day your best day. He told me that when I sat next to him at the White House. I think we have to help people to do that. But second, we should not extinguish hope, and we should be talking to people about all these things, about all these trials, about what what they can do, and about what might be coming, and that not everybody with Parkinson is the same. It's not one disease. It's not just a disease of dopamine. It's a disease of the whole body. We need to have a whole body approach for people. We need to be approaching the bones. We need to approach the skin. We need to make sure that we are looking at cholesterol levels. We're looking at hemoglobin A1Cs. We're comprehensively treating this disorder in folks, and at the same time educating people about all these things that are coming, and so that they can get ready for those things, but also remain hopeful for this generation and the next. And then finally, this is like number 3. I said I had 2, but here's number 3: prevention. We started the discussion on prevention. So there's primary prevention. That's, should we not pass this to the next generation? I think it's something we need to help people with. But then secondary prevention for people that have it, trying to slow that disease and to improve the symptoms for folks. So that's kind of how I look at it, Kevin. And I think that we just have to be humble and remember, both Soania and I are doctors. Every day we practice medicine, we know a little less, and we just have to be humble, and we have to be willing to take that journey with people.
That's true. Thank you so much. I'd love to end on those thoughts. Thank you all so kindly for joining us today. I hope you found the discussion helpful and educational. I know I always learn so much from our discussion, so thank you so kindly, Dr. Michael Okun, for your time and expertise. And remember, everyone, we may not have the choice in our diagnosis, but how we face the challenges this disease brings is ours to define. So choose to optimize your quality of life, educate yourself, empower yourself, and celebrate your daily victories. Until next time, be well and stay safe. Thank you.